Any idea?
The 20% functioning they are telling, I don't remember exactly. But the plan was to preserve the kidney.
Okay.
Because as such, the creatinine is also little high. It is around 2.
Yes.
So plan is to preserve the kidney.
My question to Dr. Sabnis sir. Sir, at what DTPA function would you call it preservation of the kidney versus not doing anything or doing a nephrectomy? Not in this particular case where the creatinine is high.
There is no such cutoff. It all depends on what is the age, what is the opposite kidney, whether patient has infection or not. Basically, now if you have to discuss about this case, this case has a neglected stone for such a long time, and I don't know whether there is any recurrent episodes of fever. Clearly, on the X-ray, it is an infective stone. It is likely to be full of pus flakes. So these are all slough-like material. That secondary stones, what Shabir was telling, is like a slough. So these cases, actually, many times they are all infective stones, and with the pyonephrosis, and therefore, in a situation like this, instead of a DTPA, we would put a PCN, decompress the system, see how much actually is the output, because often in obstructed kidney, it is a fallacious
I would like to
thing,
inject the contrast first.
because it will give false positive.
Uh,
Even in the pyeloplasty, even in the POJ obstruction and other things, often you will see that
Sir,
the
in this
DTPA shows more GFR, more function,
contrast डालो.
and when you relieve the obstruction, actually it drops. So patients are worried. अरे अब पहले तो 30% था, अभी तो 10% हो गया, अभी क्या हो गया? Because in the obstructed system,
डालिए
it's a
contrast.
fallacious this. Any obstruction, DTPA is going to be fallacious, and therefore, in a situation like this, the exact idea of functioning will be obtained only after the putting the nephrostomy.
Give me ultrasound.
Because these are all infective stones. In an infection
Ultrasound
with
probe भी दे दीजिए.
pyonephrosis, as against to the same type of stone with clear urine, the functioning will be much preserved if it is a clear urine. So if it was a stagon without infection, the preservation would be much better of the kidney function would be better as against to an infection which is there. So this patient actually is neglected stone, must be recurrent UTI, must be having pain for quite a long time. And now with multiple antibiotics and thing, it has actually infection or symptoms have subsided, but nevertheless, the pus and other things is bound to be there.
Ultrasound machine.
Dr. Shabir?
Sir, I have injected the contrast. Can you show are you seeing the CM picture? Yeah.
Yeah, we are seeing the CM picture.
After injecting the contrast, this contrast is getting collected in the lower calyx. And but there on a CT scan, we are seeing a hugely dilated upper calyx also, where we can see a very faint contrast. I intend to take a superior calyceal puncture. Probably that can give me the maximum clearance with a single puncture.
Maybe you can see some middle calyceal blotching also.
Yeah. So this needle which I am keeping, this I
वो एयर बबल है.
Can we switch the camera back to the other theater?
the status
अडेप्टर उठा के देना साइड एक्स.
jelly. Okay.
Shabir, we are not with you for the moment.
Hello.
They have shifted us to the other theater. Yes, Dr. Prashant?
We are just picking up that matrix that is there.
For analysis?
Yes.
No,
the
problem is that matrix is
Okay.
No, they were trying to
Ultrasound
tell us
also
something.
it appears to be
वहाँ पे
dilated.
shift कर देना. हाँ.
So, though I am not seeing the contrast, there is only faint visualization. I will make a upper calyceal puncture.
Shabir, just hold on. They're trying to tell us something in the other theater. We'll be back with you maybe in 30,
Normally,
40
I
seconds.
use a triangulation technique. First, I decide a point of entry, which is not very clearly because I don't have a contrast in the peripheral area, but I can see
ठीक है.
this direction, and I am taking the upper point of the stone as my point of entry. So then I draw a line. This is in a 0 degree. Give me the marker. One. I'll shift. Pardon. One minute.
So are you planning a single puncture or multiple
This is
punctures? Or
suppose my A point, that is point of entry. Now take the C arm around 20 degree towards me.
Dr. Shabir, can you hear us?
Yeah.
Dr. Shabir?
Yeah. Now you see this point shifts medially. Sorry, laterally. Take the C arm totally. मेरे साथ C arm बढ़ाओ आगे थोड़ा सा. But 1 second.
Dr. Shabir, can you hear me?
Yes, yes. Sir, I am
So-
just wanted to, though this patient does not have the pinpoint puncture area, but I would just want to demonstrate one triangulation technique which I normally uses.
Yes. Everybody here realizes that this is a difficult case given to you. The stone is everywhere in the kidney. So are you planning a single puncture or multiple
Sir,
punctures?
I tend to plan a single puncture at present, and let us see how much I can remove with a single puncture using this shock pulse machine as an added advantage. So
Okay.
this is the point A, which shifts to the point B on taking the C arm 20 degree. And this is my, are you focusing on the skin?
Yes, we can see
Yeah.
the skin.
This is
yes.
my line of entry. So once my point A shifted to this point B, and where it cuts my line of entry, that will be my site of entry. So give me knife, please.
Can you just explain this once again?
Sir, this point A that I initially in a 0 degree, I have marked as my point of entry.
Yes.
And once I shift the C arm to 20 degree, this point here shifts to here.
Yes.
And initially I have drawn a line, and this was my direction. That was a line of entry.
Okay.
So once this point of entry shifts here on 20 degree, and wherever this will cut this line, my line of entry, now this becomes my point of entry. So give me knife. Let us see, sir. Just a moment.
Any particular reason you selected 20 degrees, or is it by the
Sir,
body
because
habitus?
this kidney is hydronephrotic, all around dilated. That's why, sir. This is nothing specific about that.
Okay.
But the rib is coming in between. Let us see. I have to just shift. Give me knife, please. Knife. One minute. So now I am going in on, I will not hit my target, but I am putting my needle in slightly. And now take this, bring the C arm to only 10 degree, not 0. 10. Okay, 1 minute, leave. Okay, now it is in 10 degree. Still, it appears to, see, there is no specific target. It is difficult to explain here. Okay, so probably the kidney is moving. I am in that direction. Now take to 0 degree. Put saline from below. So it appears to hit the target in 20 degree. First I took in 10 and did some approximation and arbitration. When it is okay, going to 0, and then remove the needle. So now the water is coming.
Good.
Put some more water. We can put a contrast. It's a dilated calyx. So it will take a huge amount of contrast to fill that upper calyx. It's a very hugely dilated calyx. Sure. Now, give me knife, please. Now, give me dilator, please. I tend to go up to 22 or 24 because as it is a dilated system, so that I can use a bigger nephroscope and a bigger probe.
So what is the size of nephroscope and what is the size of probe that they are giving you?
Sir, this is 22 French nephroscope with a channel of around 12. And probe we will be using 3.76 probe size.
So that comes to around 10 French, 11
Yes,
French.
around 10.4 French roughly, sir. So I think that should work. It should have adequate irrigation also.
So you used a single step dilator and then you're trying to put in the rigid
Then
rod inside.
rod and guide rod and then sequential dilators, metallic dilators.
Any precautions you would like to advise the juniors when they're trying to do a superior calycial puncture?
So definitely we have to be careful regarding the pleura, but here probably in this case,
Especially when putting in the dilators or the flexible dilator?
sir, I don't think any particular definite precautions we need to tell. I think you can elaborate on this. Water from below. देखो यार आ नहीं रहा है इसमें थोड़ा थोड़ा चलाते जाओ.
So are you using general anesthesia or spinal?
Sir, we are using general. सियाम थोड़ा सा पीछे लीजिए, व्यू अच्छा नहीं है, पानी थोड़ा चलाते जाइए. Give me 24 sheet.
So in this case, how deep are you trying to dilate? So how do you perceive the depth?
Yes, sir, in this case, there is always a possibility of you leaving outside the system because parenchyma is thin and it tends to bend inside rather than your dilator is going in. So I am taking little bit precaution that I should be in rather than leaving myself outside the pelvic ileal system.
So maybe you're trying to take the dilator till the point where just the
yes, sir.
circle of the glide wire starts.
Yes, sir. Yes, sir. Otherwise, once I'll go in, probably I will be outside the system. Let us put water and see if we are inside the system or not. Put water and check. No, we are not. Very unlikely we are inside. Mhm. No, we may be inside. Sometimes, no, there is a large system and even the water is not coming. So, what was I am putting this dilator, the water, I could see there's some amount of water. I think let us go inside and check, are we inside or not? कैमरा लगाओ यार फटाफट यार योगेश. Let us see what was saying. नहीं अब ये लगाएंगे ना इसमें चिपका उसको. This is from Olympus. हाँ. This is a 22 French nephroscope. Meanwhile, I think they are arranging the scope. We can see this machine, sir. We can discuss about the machine shock pulse. Please remove the things over from the machine. And give me food pedal. Nitish, food pedal. This is a
Please
shock
take a
pulse.
closer vision.
This is a shock pulse machine from Olympus, which is a dual energy lithotripter, which utilizes the ultrasonic energy as well as ballistic energy. And as well as it has got a suction combined to these energies. So once you put the probe, it causes disintegration of the stone, it breaks the stone and drills the stone as well as it sucks out the stone. So now this is the transducer of this machine, and this is nose cone, and this is the probe. And these are the two switches, one is standard, one is high. If there is a hard stone, we can use this high power, or otherwise a standard mode will work. And this is a knob where is a suction control. And if we have to put a suction in around moderation. If you put too much suction, it will suck the mucosa and the water also, and then things will not be clear. We'll see on tape. हो गया, फोकस होगा, करो, पानी डालो, पानी लगाओ यार. Give me water. ये बनवा दो मेरे को. पकड़ो, दो पकड़ो, ये खोलो. कौन? हाँ, सीएम, ये बंद है जरा पीछे. लाइए. Yeah, thank you, sir. Yes, it was expected. I think we are out of the system. We can just push, put the dilator and again reposition it. Yeah, give me again that dilator. मोटर डायलेटर दो. सियाम ले आइए, सियाम दिखाइए. See, Ashish sir,
Yes.
as expected, no, we were out of the pelvic area system. Even we took a precaution. I was not inside.
Okay.
Like.
I think we don't have IRTV view.
No, now I think
Yeah,
probably we are in.
now you have water coming out.
Yeah, yeah, water is coming out spontaneously. Probably now we are in. वो लगाइए, प्रोब चेक करिए, चेक करिए. Yeah, now we are in. Please take Siam back. Siam पीछे लीजिए. So now the stone is seen, and let us see if the stone is hard, then we may use pneumo also. But if a stone is duly soft, we will continue with the shock pulse and see the effectiveness of that machine.
Does the shock pulse not work very well with hard stones?
Sir, yes, sir. Shock pulse, if the stone densities are approximately 1300 or so or more, then तुमको यार कब से बोला हुआ था कब बाहर रोकने के लिए, इसीलिए. पानी चालू करिए. ये तो चालू तो है नहीं सेक्शन, ये भी नहीं. पेडल से चलेगा बस, ठीक है. Some secondary stones are also there. इसलिए तो वो बाहर बोले थे रोकने के लिए. हो गया अभी? हाँ, चालू हुआ. न्यू प्रोब है, इसका सक्शन को थोड़ा सा करिए. One more important point here is to manage the suction. If you do a lot of suction, no, then the mucosa also collapse and nothing is seen.
So what is the height of the irrigation you are using at the moment?
Irrigation is, please make some hole in the irrigation. It is not coming properly. The irrigation height is around 60 centimeters. The stones appear to be soft, sir. चंद्रमोहन है क्या? चंद्रमोहन सर हैं?
So the shock pulse machine will not give you irrigation fluid. You have to take irrigation from outside. It will only suck the fragments along with pulverization.
पानी आने दो यार, पानी आने दो, पानी आने दो. Air. If there is less of water, no, there is some air bubbles come. So
Moving it first.
So there is question,
question
in the
is-
audience.
The-
Hello. There is question from the audience.
one more, yeah.
You are not removing the secondary stones first. You are hitting this one stone. Any specific reason for that?
Pardon, I didn't hear, sir.
The question is that there were satellite stones or secondary satellite stones. You have not preferred to remove them first. Rather, you are directly going on to the bigger stone.
First, I was just trying to see and check that how was that stone consistency. This is soft and these stones are harder, but still no, they will also come. If I first suck them, no, they may get stuck up in this probe.
Okay.
And then you require to use some stillet to remove those stones
Yeah.
from the probe. So I think just I will do in between.
But even the secondary stones,
This probe is
actually
not
of this
new, yeah.
type, with shock pulse,
probe
they
कहाँ
get
काम कर रहा है अच्छे से? probe कहाँ है गंदा?
they get sucked out very well.
ये न्यू प्रोब है
They
बेटा.
get broken up and then they get sucked out very well. For secondary stones, actually shock pulse is quite
गाइड वायर
good.
निकाल देते हैं फिर.
It will be amazing that they all will get broken up and
we will
sucked
take
out
a guide wire
very,
out.
very fast.
इनको निकालो, गाइड वायर निकालो. एम्प्लास ध्यान रखना. गाइड वायर निकाल दीजिए. This is not DLC. Why you are not giving DLC probe? 3.4. This is what, 3.7? Okay. Let us see with 3.7. See, there are sir, two sizes available to use with this, 3.4 and 3.7. And there are two types of the probes. One is the normal probes and another is the DLC probe. DLC is the diamond-like coating probe. That is a black color probe.
So is this a black colored one?
आ रहा है क्या?
Which probe are you using now, Shabir?
Sir, this is a normal probe, not DLC probe.
Okay.
But the size is bigger, that's why I am
Shabir,
using. Sir,
If you use 3.7 probe in 22 French Olympus, your irrigation will be very
आवाज
less.
थोड़ा बढ़ा दीजिए ना. बेटा वॉल्यूम बढ़ा दो इसका स्पीकर का.
If you use 3.7 mm probe with a 22 French Olympus, then your irrigation is going to be less.
Okay, sir.
Whereas with 3.4, the irrigation is much better. Otherwise, you have to use some pressure or something for irrigation, because unless and until you have a good irrigation,
It will not work.
vision will be poor and suction will not be that effective.
निकाल के बेटा खोल देना. 3.4 भी लगाओ जरा.
Carbon coated probes is a new invention,
इफेक्टिव आ ही नहीं रहा है.
which
ये बंदा
is actually for the durability. It gives strength to the probe.
पानी को बंद करो यार.
But I feel this sort of a stone is the most ideal for the shock pulse. Now you will see yourself that the way in which it will get fragmented and sucked out will be very, very fast and very, very effective.
नहीं चल रहा है यार ये.
The difference between carbon coated and this metallic probe is that at the end you will see that there will be shiny metallic particles which will be there on the mucosa everywhere, and they will be shining, although it has no relevance, but that is what it happens. That see, now you can see here at somewhere there are some shiny particles which are there, So that gets spread over all over the mucosa. It is of no relevance. Initially, we were afraid that whether it will cause any problem or not, but it doesn't cause any problem. And therefore, with the carbon-coated probe, which is a black-colored probe, this problem gets sorted out. It does not cause any shining particles.
लगा रहा है.
Cost of probe is about, I think, 30,000 or so.
I'm changing this probe to 3.4 size, and let us see what change it makes.
See, 22 French Olympus, you have to use 3.4. Otherwise, your irrigation is going to be very, very less.
Yeah, because
You will face problem.
sir, even company people told me that they are using the similar combination in demonstrations. So I have used that. Let us see, sir. I'm using now DLC 3.4.
When we use this Olympus 22 or the Wolf Dresden, 3.4 is the standard probe,
Okay.
which gives adequate irrigation, and then the effect is far better.
Vision is also not good. Vision जो रहता है ना, उसमें नहीं है.
On an average,
Life of the probe, this carbon coated probe actually goes on for about 10-15 cases.
the probe, I mean, the per case cost of the probe would be 4 to 5,000, if I'm not wrong, sir.
Sir, cost of the probe which they are giving is around 22,000.
And it would last for maybe 4-5 cases.
Or maybe more. But
Keep-
on
keep
an average, it
pneumo
is
also
4 to
ready.
5.
Keep pneumo also ready, and forceps. Yeah, let me go inside the pelvic elevation system. So there is a lot of tissue edema also
Yeah, you
adjacent
can
to
see
the
that
stone.
it is all expected because of the obstructed, usually dilated
Yeah,
system.
so
Any special precaution when you are nearing the mucosa?
sir, normally we should not touch this, but even if you touch, there should not be a much damage as we have seen at many occasions. It does not cause as much. But sir, this appears to be something very fussy. Appears to be some.
No, this
means,
is the embedded thing. So you just keep on doing that. Once you go up to the main stone, there will not be any problem.
This
so in
usually,
such a stone, sir, should we think of some malignancy also
No,
inside?
this is all impacted stone.
So see this area, which
Yeah,
is all
agree.
around
So
it is
these
a
are
stone.
all tissue-like stone, which is there, which often seen in the impacted, long-standing stone.
Give me some
You
forceps
will
also.
you will get appearance like a tissue in the stone.
yes, we actually did a series of this
but sir,
in
this is
which we
bleed-
sent this for histopathology.
It is bleeding also.
And yes, it will bleed because there will be some haversian system that can be seen on microscopy in this tissue. So we did the largest series of 35 cases
Okay.
in which we sent this for biopsy thinking that it is malignancy. But the pathologist reported haversian system which is formed inside the stone. So actually they call it bone in stone kind of a phenomena. And this appears typically in chronic stones which are obstructed.
Achha, sir.
So this is nothing to worry, Shabir. You just you are in the proper direction. You have to just keep on breaking the stone. You will go to the main system.
In sir, a few years back, around 2 years back, sir, I came across one malignancy in such a staghorn, and
Yeah, but
turned out to be a TCC.
that's in the mucosa. This is inside the stone.
Infundibulum. Yeah, it is. Yeah, but it is the jam pack, and it is bleeding also. And sir is telling that it is not malignancy, but pani, water.
Give little pressure over the irrigation system. Once you have a good irrigation, things will be very fast.
Yeah, please give some pressure from the pump.
It's an open system, so you don't have to worry about the high pressure.
Give me pneumo also, please. Just let me use pneumo also here.
Pneumo is automatic in the this,
Yeah.
Shabir.
Sir,
Why do you need pneumo?
Pneumo is automatic. It's a combination. In the triology, you have option to select how much percentage pneumatic or ultrasonic you want, but in the
yeah,
shock pulse, it is automatic.
yeah, CM. See, चले
You are actually doing right. You just have to keep on going in that. Once you go and make a tunnel inside that stone, it will get little disimpacted, and then you will go to the main stone.
क्या लग रहा है? Sir, just I am trying to do sir peripherally and
Yes,
let us
yes.
see.
Maybe you try to keep in the center of the stone rather than the periphery.
Yes.
Center part is bleeding little bit.
That is some
Not
minor
necessary, they all
tissue
will come
which
out.
will be part of the stone, so need not worry.
It is bleeding little bit more.
Don't worry.
कौन सा स्कोप है ये? Give me some pneumoprobe. One, just I want to just put a pneumoprobe and see if I get a space.
Yes, that will be a good idea also.
Yeah, sir. नीमो लगवाओ. नीमोलिथोट्रिप्सी प्रोब 1.5 दे दीजिए नीमो का. भाई टेक्नीशियंस को एक आ जाओ. नितिश नीमो प्रोब दो यार.
Sir, you are changing the scope also?
Sir, vision is a little better with the scope. No, they give me pneumo. Give me paddle. थोड़ा सा लेजर भी लगवा के रखना भाई.
Where you
Dr.
see the
Ashish?
where you see the crack may be a better choice to go in. You can see the crack at around 2 o'clock in the stone.
Yeah.
Yeah.
Give me forceps also, please.
Yes, there. That might be a better place.
Yeah, probably this is the place where I think we will
Yeah.
go in the system below.
And taking a forceps, you can start plucking out those fragments.
Yeah, give me forceps, please. Yeah, give me forceps. I think once we make some space, we can use this shock pulse again.
Yeah, correct. Maybe a peanut forceps would be a better choice. That would have been
But
my
this
preference.
will be the part of a big staghorn. It's a branch of staghorn. It's not a separate stone. You have to
Peanut
just
do?
keep on
Instrument, sir?
breaking, keep on breaking.
Now give me again shock pulse and see.
You are actually going to the main stone now.
Yeah. Give me shock pulse.
There'll be a tissue core in these kind
Yeah,
of
so
stones.
that tissue core should not worry. It is a common occurrence in the chronic
Yeah,
impacted long
मुझे ना
stem
भाई।
stone.
Hmm.
It's breaking quite effectively.
टाइट चल रहा है इसमें। नहीं, सेम आई वांट टू। Hmm. Yes, I also want to go to side. नहीं जा पाएंगे। It's like fitting in a yeah, tight fitting.
I think lower down around 3-4 o'clock, you have good amount of stone core there. You can
Okay.
pursue that, yeah.
In between, you can check on fluoro how far, where exactly is your direction, how far you have come. But as you keep on breaking down, this will get separated out, and then suddenly you will see that there is a dilated system. Space will get created. Yeah, correct. Think.
Or should I take a laser and use in high frequency and just when we can try it?
What actually you are doing is quite all right. That's what I feel.
Yeah, just try to push that shell into the center.
Yeah. So that 3 o'clock, 4 o'clock, 5 o'clock.
Because I'm making a well, so going inside, but the margin is not. I'm not able to.
Pull those
Clear.
margins inwards.
Yeah. Water, please. Water. Funny.
This is a big stone. It is going to take time. All these manipulations are required. It's not a simple case. It requires angulation. It requires manipulations. It requires multiple punctures, multiple tracks. These are all one has to be ready with such kind of stones. So what actually you are doing is quite okay. Main bulk now, as you see, you are going to be laterally facing 4 o'clock or 5, where the extension is going into the middle and the lower calyx.
Yeah, that
So
region.
eventually you will have to angulate.
Yes, sir.
Yeah, that region.
Correct. So that is where the main bulk is extending into the lower calyx.
Sir, I think now, sir, the noise has changed. Probably this material is now.
It's
It's
coming
stuck
to
up.
an end. It's coming to an end.
No, sir, material is stuck up in the probe.
If it is not, then you have to There might be some blockage of the
And one
probe.
more thing is using this is once you go more deep, no, then there is more chances of this material going stuck up. So you have to take a small bite, come back, and again put your probe at one place, different site.
So that sound has changed, then it is also possible that probe may have get blocked. Because sometimes probe also gets blocked.
Logged.
So what actually you are doing is right now you have to angulate to that 4 o'clock and then you will see that extension. So this is a dense stone.
Can you give me one probe so that I can lift the stone if
Yes.
possible?
Yes. No,
ड्रिल नहीं हो रहा है सीएम, बट आई वांट द लेटरल पार्ट टू आल्सो कम ऑन दिस साइड.
Shabir sir, can you hear me, sir?
Yeah,
I'm
yeah.
Dr. Yogan. Sir, we will be taking you in picture mode, and
Okay.
meanwhile there is a lecture from Dr. Sabnis sir.
Okay, sir. Okay, thank you.
Okay, sir.
Thank you.
Thank you, sir. I invite Dr. Sabnis sir for his lecture on troubleshooting in PCNL.
अभी आया है.
well, at the outset, I would like to thank the West Zone entire council and Dr. Kamlesh for giving me this opportunity to be the part of this fantastic conference. And I'm giving a lecture on troubleshooting in PCNL. That's what I was told. Well, there are a lot of problems which can occur in PCNL. And there are some problems which are common, there are some problems which are rare. And therefore, when he told me that there should be a lecture on troubleshooting, what actually is troubleshooting? It is not the how you manage the complications of PCNL. That's not the part of this lecture. But troubleshooting means when you are actually doing some the procedure, you come across some problem, and then you find out as to how to overcome those problems. That is what is troubleshooting. And I'm going to talk very briefly about some of the aspects of troubleshooting in this 10 minutes lecture. Well, it's a very long lecture, but I've cut down to a thing where we can fit it into 10-15 minutes. First and foremost is the puncture. As you know, in PCNL, we know all the time that perfect puncture is the key to the success. If your puncture is proper in an appropriate way, then your half of the procedure is done. So you have to spend a little more time on puncture because that's a key part of the procedure. See the images, see the previous investigations which you have done, see the ultrasonography image, see CT scan, where exactly is the anatomy of the calyces are there, and then you need to carefully plan. This is also should be done beforehand. And once you plan everything, then you have to execute that plan. And often the retrograde pylography will give you the final answer. Often we have seen the system which appears to be very spastic, very difficult. When you RGP is a dilated system and becomes a very easy system. So ultimately, whatever you plan everything, final planning is going to be after you put a ureteric catheter and after you inject contrast and see the system the way you are doing. The next thing is the puncture. Quite often we see that the residents and other people, when they puncture it and when they get fluid on the first shot, they feel very happy. Are fantastic, the job is done. No, but that's not right. just getting fluid, just making a puncture into the system, and just getting the contrast out of fluid is not right. You see here, although the on first puncture the thing came in, you got the fluid, but when you injected contrast, and therefore when you get a fluid, always good idea to inject contrast to see how you have gone into the system, because how you have gone in the system is very important. You see here, although it has gone into the system, it has not gone properly. This is the calyx, there is a stone here, this is the infundibulum, this is the pelvis, and this infundibulum actually is blocking this is a calyx, and this is what is dilated. And while puncturing this calyx here, actually the puncture has gone into through the infundibulum into this calyx, which is dilated, and therefore you got the fluid. Injected contrast, now you see that this is not a proper puncture. If you dilate this system and dilate this tract, you are bound to face problem, because you will not be able to see the infundibulum properly, because it is not going into the proper direction. So discard this puncture. This is not a proper puncture. Simply because it has gone into the system does not mean that everything is fine. So withdraw this system, withdraw this needle, and do a proper puncture. Now you direct it. Now it has gone properly. It has hit the posterior calyx. Now you inject contrast, it is filling this posterior calyx, then it is going here, then it is going here. Now to put a wire, and now wire will go inside the system properly, and this is the way you have to puncture it. So that is how, don't accept the puncture which is half-hearted, the puncture which is not as per what you wish to have, just because you think that whether second time you will get puncture or not. Many times once you get fluid, there is a hesitation that, again, whether you will get the system or not. So let us go ahead. Don't compromise. You are bound to get it. Not one attempt, not two attempts, doesn't matter. Even if there are 2, 3 attempts, it doesn't matter. But make sure that the way you puncture is appropriate. Sometimes you get blood on the puncture. Now, when you inject fluid, the fluid comes in, blood gets a little bit cleared up, but again, there is a significant amount of blood which comes in. This is in the system, partially in the system, but there is some blood which is coming up. You inject a lot of fluid from ureteric catheter, and then you see that a little bit clearing of a blood, but again the blood keeps coming. Discard this puncture. Don't be in the temptation that it is inside the system, fluid is coming, or it is all right, all right. Eventually, what it means is that you have hit some significant size vessel while going into the PC system. When you are dilating this tract, you are bound to land up with a major bleeding. So discard it, no problem. You will achieve another puncture which is going to be a proper. So don't accept just because you got the fluid and it is clearing little bit. The other thing which I was telling in the morning also is to avoid the zigzag track. What does it mean? That when you make a puncture, when you decide the puncture from the skin to the pelvic-calyceal system, go in one go. Often what happens is that many people do, you go this way and again go upward, again go this way, eventually go into the system. But then what happens is that when you withdraw the needle, you realize that your tract is like this, like this. Now this tract to dilate becomes very difficult. Even in the morning when I did that case, it was awkward puncture because it was quite low down and it was a little zigzag track. It was not a straight track because we had to go inside and then actually move it down. So that's not a proper track. Ideal track is a straight shortest distance, and therefore avoid the zigzag track. If the tract is zigzag, it will, previously we used to use PTFE guide wire which used to get kinked. Now the glide wire is all right, but the glide wire doesn't have that stay, because if it goes in a zigzag way, the glide wire doesn't have strength. If you are using zebra, if you are using super stiff, it is all right, they have a strength. But a glide wire doesn't have strength, and therefore in a zigzag track to dilate becomes difficult. And you have to remember the direction in which it is going from one angle to other angle becomes very difficult. So this is how you see that this is a problem, that the same case, it was not properly done. Again, withdraw a little bit. Again, it was done in a 2-3 attempt. And then when you take out this is what happens, that now you are dilating a zigzag track. The track had come like this, and it has come. Now you are using a 6 number 8 millimeter Teflon dilator. It is actually not going in a proper direction because the track is zigzag. The other problem is that because of the impacted stone, the excessive wire is not inside. If the excessive wire is inside, then you can still do a lot of manipulation and make sure that that angle is rectified properly. And therefore, if your angle is not proper, if your wire is not that much inside, you are going to face a lot of problems with this. And therefore, that is the way you avoid the track. So in that situation, what would you do? The Teflon dilator, which is a little softer, will not negotiate that angle. So often you take a rigid instrument. You can use the Alkin's needle, or you can use little stiffer the dilator, oversized dilator. So that will have a strength. And once you negotiate the angle, negotiate the direction, then you can go into the system. Then you may change to a different wire, or you space the wire properly, and then dilate the tract properly. Once you put a rod, once you have a rigid rod inside, no problem, that will get dilated without any problem, because it gives stability. Now, once you put a rod, that angle and everything is straightened up, then you have no problem in dilating the tract. Next thing is the wrong angle, which can cause problem, and therefore that actually comes with the proper planning. Now here you see that there is a stone impacted into the PUJ, and it was improper to go from this angle. It is a wrong angle, especially in a kidney which is thin, buckling kidney. If you keep on dilating with this, the kidney will go forward, and you will not get that angle. And every time when you put this angle, your force actually is going here. It is not going in this direction where it should have been, because your angle is not proper. And therefore, this odd angle will always pose some difficulty. And therefore, your angle when you are puncturing has to be proper. This is one problem which you will always keep on facing. The other thing is the underdilatation. As you saw, even Shabbir also faced this problem, especially in a dilated system, especially when there is a parenchyma is thin, the parenchyma has no strength, the kidney is buckling. And therefore you think that it has gone inside, but actually it has not got inside, because as you keep on pushing dilators, the kidney keeps on going forward. And on C-arm, you feel that it is actually gone inside. Here you see that everything has gone inside, but actually it doesn't go inside, because kidney also has gone forward and it has not pierced the parenchyma, and therefore that's an underdilatation. Underdilatation problem you will always face when you do a one-step dilatation, because what happens is that you put the puncture needle, put a wire, put a guide rod, and now you are putting a big size dilator as a one-step dilator, and therefore enough parenchyma is not, the hole is not created, and that is where you will end up with the problem. Now here you see that it is the underdilatation. You see, when you put a thing inside, it is all outside the pelvicoalveolar system, outside the kidney. You see at one hole there is a wire which is going inside, which is going properly, but you are not able to find the track properly. So how do you rectify it? There are multiple ways to rectify this underdilatation. First thing is that, again, you withdraw the scope, put a rod properly. Rod, had gone properly. Take a appropriate size Emplart's dilator and force that dilator inside with the circular movement. You will go inside the system properly. That is one way. Second way, if it is not happening with single step dilators, then you do a gradual dilatation. Rod has gone inside. Now, instead of using a single step dilatation, you do telescopic dilatation. So the smaller size dilator goes inside, over that another dilator, like that, then you will be inside the system. Other thing is that if your wire has gone properly and you see that it is a small tiny hole in which you negotiate with the smaller scope inside the sink, and now once you go inside, then you can advance the implants over that thing. That also can be done. So these are multiple ways in which to correct the underdilatation. Sometimes you have a problem of overdilatation. Overdilatation happens when use excessive force, especially in the previously operated kidney, or especially when you are forcing it not in a proper direction. So in that case, what happens is that you have put a rod inside, and now you are putting the telescopic dilators, or you are putting the single step dilatation, and in the process, if you use force, then it overshoots it crosses the pelvic system, crosses the pelvis, and actually pierces the parenchyma on the medial side. So you see that the contrast extravasates, it creates the hole, the rod goes inside, the wire goes outside, it goes outside and again comes inside the pelvic system, and there is a medial perforation which comes in. So that's called as overdilatation. So to prevent this problem and to overcome this troubleshooting is to do a gradual dilatation. If you are not much experienced, don't do single step dilatation of a large size. Go in a gradual way. Even for the mini PCNL, go gradually for 6 French, then 8 French, 10 French, 12 French, then 14 French. Then this problem will not be over. Other thing is the method of doing dilatation. Never use force. Everybody, even today in the demonstration, everybody has shown that force is not required. You just have to rotate. You just have to rotate the dilators in such a way that it creates the space for itself and then gradually advances over the previous dilator. So force is never to be used. When I do dilatation, when you are doing the this, I don't hold the guide rod at all, because when you are holding guide rod and with the other hand you are forcing it, inadvertently either you will pull or you will push the rod, and therefore when you are using the dilatation rotational movements, you just have to rotate it. Let guide rod remain where it is. There is no problem. It will not come out. It will not go inside. It will not come out. Once you do rotational movement, gradually the dilator will get advanced. Doesn't matter even if it takes a little more time, but have patience, give some time. Eventually, it will dilate completely. Otherwise, you will end up with such type of a problem. This is how you dilate. Now you see that there is a rod which has gone inside. This is the rod which goes properly inside the ureter. The wire has gone inside the ureter, stable tract. So every time you see this, and now you see that make the previous dilator wet. You have to ensure that you are doing a proper dilatation in a stepwise manner. Don't jump it. Now this is how you don't even have to hold the rod. You just have to do rotational movement. If you see here on fluoroscopy, stop at the point where you want to stop it. Now these are the screw-like movement which is seen. These serrations which are there on the Alkin's telescopic dilators, they are meant for a proper grip. Why there is a serration at the distal part of thing here is simply because that is where you have to hold it. The other hand is at the skin level, and then you make a rotational movement. See, now that is how you make the rotational movement over the telescopic, over the last dilatation. Again, you are not holding the rod at all, just rotational movements. On that you slip the implants. Once you know that your implants is properly inside, then you take out the rod with the telescopic dilators and you are inside. So this is the very easiest, very safest, and the best way of doing the dilatation. The other common problem which people come across is the perforation. Now, if you make a perforation either in the calyx or in the pelvis, and some fragments bound to go outside the system, often there is a temptation to take out those fragments. One or two small fragments easily seen, it is all right. But in the process of taking out those fragments, you push your nephroscope outside, see the fragment, they all get embedded into the fibrofatty areolar tissue, and then you have to put the forceps. In the process, you make perforation wide, and that actually is counterproductive. Doesn't matter even if those stones remain outside, absolutely of no significance. Even though they are seen on the X-ray, on the post-operative X-ray, explain to the patient there are some fragments which are outside, they are of no consequence, they are not in the system, it is not going to cause problem. But in the process of going outside and making sure that something should not be seen on the post-operative X-ray, you take out this fragment, you make the hole bigger, and if that hole is near the PUJ, that tear may extend into the pelvic pelvicollateral on the PUJ, and if the PUJ gets torn like this, and then later on it heals by fibrosis, you have a lifelong problem. Secondary POJ obstruction following PCNL is a lifelong problem. It will never get sorted out, and you will end up with lots and lots of problems. So avoid that problem is to avoid the temptation of taking it out, going out into the pelvic system and taking the fragments out. The another important troubleshooting is going from one calyx to other calyx. Now, that's a very important thing. If you have a stone, you have punctured a middle calyx, and you have a stone in the lower calyx, you have a stone in the upper calyx, and you want to take it out. You see that pelvis is completely clear. Now you see the opening of the lower calyx. You angulate, the stone is lower down, you still further angulate. At one point, you have to stop it. Too much angulation is absolutely hazardous. Never angulate too much. What will happen that, okay, everything is front of you. You have seen the pelvis, you have seen the PUJ, you have seen the opening of the lower calyx. Now angulating. Excessive torque is there on the infundibulum of the lower calyx. And if you make excessive torque, you will be able to go and see the stone. But moment you withdraw your scope, you will find that there's a bleeding all over. Your whole vision will become red. There is excessive bleeding. That is simply because that infundibulum has got torn because of the excessive torque. So avoid, if it is easily seen, if it is a smaller scope, yes, you can go inside, no problem. But in the temptation of doing everything with single tract, not avoiding the puncture, actually you are going to cause more problem. You are going to come more in trouble. And therefore, either in the upper calyx, whichever calyx you are showing. Now, Shabir also was doing that, and there was a angle which was there. If there is an excessive angle, avoid it. It is easier, better, safer to make another puncture. There is no problem in making multiple puncture, rather than having an ego issue that I will do everything from one puncture. No problem. Quite often, single stone, you don't want to make a puncture. You see a very small stone which has gone actually in the lateral most calyx. And there is a temptation of going into one calyx. Wrong. Avoid it. If you want to use it, use a flexible nephroscope, go inside that calyx, catch it with Basquiat, take it out. If not, put a nephroscope, make a puncture. Often the stone which is migrated from the main system to a awkward calyx, you can flush it out into the main system and then take it out again from the main system. If it is not getting flushed, it is not getting this, it is safer and easier and better to make a separate tract, make a separate puncture, make a separate tract, take it out. There is no problem at all. Having multiple tracts is no problem. Rather than, it is better than making an issue of going and giving a torque to the system. So these are some of the problems which one can face and that has to rectify. The other simple thing is to keep a watch on the returning fluid. You will see that inadvertently, if your implants comes out in front of you, everything is fine. But your implants comes out, it is in the tract. And you will see that there is a significant amount of blood which comes in. You will see this again. That the trick is that now you see that implants has come out, significant blood is coming out. It is simply because implants is in the tract. Now you just have to push it inside the pelvic system. It is all clear. So these, when you, as a surgeon or as a student, you have to always keep a watch. Your watch should not be only on the monitor. Everything is fine. You are doing this, but here there is a lot of blood which is coming out. So either nurse or assistant, or you have to see intermittently whether it is the return is very clear or not. If it is a very simple maneuver, but within a short time, it can cause a lot of bleeding. So these are all troubles which you can face when you are doing PCNL. And these are all small things which are quite easy to follow, which will make your procedure quite simple, quite safe, and with a better success rate. Thank you very much.
Thank you. Thank you so much.
Yes. So pushing the stone, puncture wash is a very common thing. So especially if the stone has migrated into the awkward calyx from the main system where you are actually breaking, very likely that this stone actually will go back into the pelvic in the main system. So you make a puncture and give a wash, and it will come into the system with the same implants. You can take it out. Right? Thank you very much.
Thank you. Thank you, sir.
Thank you very much, sir. So now I request 1 minute, sir. Sabnis sir, please be on the stage. I request Dr. Ashish Patil sir to give the memento to Dr. Sabnis sir.
सिस्टम। तो देखो विजन कैसे इंप्रूव हो गया अपने आप। देखा एवरी टाइम। हेलो, ऑडिटोरियम, am I connected?
Yes, sir, you are connected.
Okay, so लो पकड़ो ने राहुल. So we are taking again a case of RIRS, and so this is almost a 1.5 centimeter size to 1.2 centimeter size stone. You can see there is a stone here. Bilateral double stents are in place. The stone appears to be not very hard, and the double stent was placed on 27th of the last month. So I think it's almost a 1 month. And are you getting a good vision of the endoscope?
Yeah. Yes.
Okay, fine. So the plan is to use, this is again a deeper scope by UMD, this 7.5 French scope, and there is no surprise for this case, at least it looks like. So it seems like a pretty straightforward case. You can see the stone. Now, I just wanted to emphasize 1 or 2 points, and Rahul is assisting me with the same anesthesia team which we had in the morning. Can you please, Nani, you allow to open it? छोड़ो, मैं कर देता हूँ. And please feel free to ask me any questions you want to ask. Moderators, please.
Sure.
So, 2, 3 important practical tips I am going to tell you, because once I'll start breaking the stone, it will become monotonous. So, the radiation is a major concern while doing a PCNL or even a RIRS. So, how to avoid it? Now, in this page, my first step to do any flexible ureteroscopy is to do a 4.5 French semi-rigid ureteroscopy. So, that is my first step for all the patients. So, I avoid
So
to
even
put
for pre-stented patients?
for any patients.
Okay.
For any patients, it is 4.5 French. Normally, I don't pre-stent the patient, as I said, in the morning. So that can avoid, I'll avoid putting a larger caliber instrument in the urethra. So urethral stricture incidence can also be less. That is one. Secondly, when I do a semi-rigid ureteroscopy with the 4.5 French ureteroscope, I can make 3 assessments. One is the ureteric orifice, second is the course of the ureter, and third is the grip of the ureter. So, and if there is any surprise in the ureter, like a stone or a tumor, you can find out. Now, generally, it is indicated that you do a cystoscopy, do a RGP if you have no preoperatively CT scan, CT IVU or simple IVU, so that you don't have an idea about the course of the ureter. So that time, some people do a RGP with when you are doing a semi-rigid ureteroscopy, but I am not even doing that, because I make my assessment based on my finding on ureteroscopy, so that I can avoid radiation. That is point number 1. Second important thing is some people do want to know about the pelvic anatomy of the pelvic alyssal system with the help of a dye study. So what I do is that I place the guide wire through the ureteroscope, so I can avoid a radiation. I'm not doing a RGP. Once the scope is, the guide wire is in the pelvic alyssal system, I backload my ureteral access sheath with the tactile feedback into the ureter. If the ureter was too tight, I will not do it. I will do use a C-arm. But otherwise, if the ureter was pre-stented like in this patient, or ureter is very friendly, in that case with the tactile feedback only I can go into the ureter, so I avoid radiation. So far I have not used radiation. People used to do a dye study to identify where the stone is located in the pelvic alyssal system. But with the experience, I think probably you can enter into the any calyx, so you can avoid a radiation. So these are the places where you are using radiation, which I have avoided. So radiation is almost nil. Once I finish the procedure, at the end of the procedure, I make assessment of the pelvic alyssal system visually. So there is no stone left inside. And then I do a dye study. That is the first time I do a dye study. That is to assess whether my intrarenal pressure has caused intravasation or extravasation. So that will decide, that will tell me that, okay, there is a possibility of some kind of post-op fever or septicemia, or how long we have to keep retain a double J stent. So if the pelvic canal system is clean, either you can put a ureteric catheter as a stent, external stent, or you can put a double J stent which can stay for a very short time. So, and you can selectively place a double J stent in any calyx you want to put. That is the reason I do a dye study. Otherwise, I don't do a dye study during the RIRS. This is my normal protocol. I do a dye study when I don't find the stone, like in a callicial diverticulum, or when very complex pelvic lysis system, there are multiple stones and I want to be very sure that I have entered into each and every calyx. That time only I do a dye study during the RIRS procedure. So in this patient, now having said, you can see the stone here and there is a laser fiber in, and I hope that you are getting a good vision. Rahul, thoda pani dalna padega. And I'm using a thulium fiber laser. My laser settings are 0.7 joule and 15 frequency. So total 10.5 watt I'm using. Okay. Any questions so far, friends? Okay, fine. Thank you. Okay, so ready? We'll go. My idea will be to produce a dust. The stone appears to be soft. When there is a very soft stone, the moment you apply laser energy, it will start breaking rather than producing the finer dust what Dr. Nanjappa could produce. So harder the stone, better to get the dust in the initial part. Once you reach to the core of the stone, then you will produce fragments, and then you have to produce fragment and take out with the help of a basket. Here, probably we don't have a basket available at this moment, but I will see. So I'll start. Okay, now my idea will be to reduce the larger stone into a small stone. So, okay, now I'll start. Okay. Because of the respiratory movement, the stone moves. I'm helping it to my advantage. So that it is as if I'm painting the stone, you can see, as if I'm painting the stone. With the respiratory movement only, the stone is getting disintegrated. Now, some people at this stage, they will push the stone into the calyx and then do a popcorning straight away so that the procedure can be over in 5-10 minutes. Now, let's see that with this modality, with this style, I'm doing a painting and chipping. You can see that. And I'm taking the advantage of the respiratory movement. Okay, so I'm keeping my scope steady actually. Any question you have?
We are intently watching you.
Oh, really? Okay, so we are, as you see that I'm going from periphery to the center. This is a periphery only I'm taking care of at this moment.
Do you
Okay.
find there's any difference in lasing by keeping the laser fiber right in front of the stone, then lasing it from the side like you're doing now?
See, when it is said that when you are using a holmium laser, that time you have to keep the fiber slightly away from the stone. The laser fiber should at least you have to show the face of the laser tip to the stone. While in case of a thulium fiber, it is said that you should be in a contact with the laser, the stone to be effective. Here you can see that as if I am doing a holmium laser only. I am not dipping the stone into the laser fiber into the stone, because then it will produce the sparks as well as it will produce the carbonization. Now here you can see that there are no sparks which are produced, which is a inherent, I think, characteristic of a thulium fiber, but you can see that there are no sparks produced so far. Initially, I was using frequency of 100 because the advantage of thulium fiber laser is that you can increase the frequency quite high. So when I initially started with this stone management with the thulium fiber laser, I used to keep my laser frequency setting to 100 in order to speed up the procedure, and joule were 0.1 or 0.2. So the total energy was not exceeding more than 20, 15 to 20. Maximum I go up to 20. But then I have changed my laser setting because that was producing sparks. So we are doing a study now whether the higher frequency as well as the stone composition are responsible for producing sparks as well as the carbonization.
In particular case, what is the frequency?
Right now, the frequency is 15 and the energy is 0.7. So total power which we are using is 10.5 watt. Now, so then there is a discussion that why do you need then use a thulium fiber laser if you are not using frequency at maximum, which is a possibility with the thulium fiber. Then what is the point of buying a thulium fiber laser? That is another question. Now it is said that thulium fiber laser is 4 times speedier than the holmium laser. You can appreciate now difference in the surface. This is a periphery, this central part, and you can see that this is the top part of the stone. So I'll go here. My idea is to reduce again a larger stone into a small stone. And with this quanta machine, I think there is a possibility that you know exactly how much time you have taken so far. So right now, our lasing time is, what is the time now? It is 3 minutes and 28 seconds.
So, Dr. Kandar, do you feel that the composition of the stone, for example, if you have more oxalate, would cause more sparking in thulium as well?
Correct, Hashit. Very much correct. The harder the stone, better, more the chances of producing the sparks as well as the carbonization.
And would you prefer the laser tip to be facing the stone directly rather than being tangent to the stone? What is your preference?
I would like to show the face of my laser fiber tip to the stone, like I'm doing it here. You can see that it is hardly touching the stone.
Yes.
Now it is said that if you want to be very effective with the thulium fiber laser, because the bubbles which are produced by the thulium fiber laser are very small as compared to the bubbles produced by the holmium laser, which is also known as a Moses effect. Moses effect is a production of a bubble, energy bubble. So with the thulium fiber laser, you can produce a very small bubble. So for that bubble to be effective, you have to be very, very close to the laser fire, sorry, the stone. Here
So-
you, yeah, please.
What kind of stone do you think this is? A soft one, a hard one?
I think this seems to be intermediate or maybe around 1200 HU. I don't know because we don't have a CT scan again for this patient. So I have no idea. This looks like not a very soft, not a very hard stone. Like what you had with Dr. Nanjappa, probably it was a hard stone.
So now you are lasing continuously. So there was a question a while ago whether we can use the laser continuously. But I
Okay.
think you're demonstrating that you're continuously lasing, so you should be okay with the machine.
It is okay for the machine,
Yes.
but I think probably you didn't notice that I gave a pause of at least few seconds in between. Normally, up to 3-4 minutes, I do continuous lasing. Now, the problem with this laser thulium fiber was that it increases the temperature. That's why it was suggested that you can you wait for some time before. So in short, you don't continuously press the pedal. You wait after 3-4 minutes. You wait like this so that it can give a rest to the machine, decreases the temperature because you're constantly irrigating the fluid. You may use even a cold water. This is what people suggested, that you can use a cold water rather than, so that the temperature in the kidney goes down. Secondly, you have to got a ureteral access sheath in position, so it is continuously draining. So there is no accumulation of the heat in the kidney pelvic lysal system. So you can continuously use the laser at least for 3-4 minutes. And when you pause, you also get some kind of a rest. Here you can see again that I'm going from periphery. And it has to be very fine, as if you are chiseling the stone. It should be very, very fine movement. And your laser fiber should not touch the mucosa. That is a more important thing. So you have to, because the respiration, the kidney moves little bit. If there is lot of respiratory movement during the surgery, your anesthesiologist can come to your rescue. What they can do is that they can produce hypoventilation. They decrease the tidal volume to about 300. And sometimes they can also produce a period of a short apnea. This is usually more relevant when the stone is in the upper calyx, where the respiratory movement may hamper the uh, your performance. So that time sometimes you need to have a. In this patient right now we have the stone in the pelvis. So I'm not suggesting anything to the anesthesiologists. They are doing their job fantastically, and we are fine. ETCO2 should be measured when you do this kind of a thing, and watch for the pulse rate as well as the blood pressure. And if ETCO2 rises, in that case, wait and tell her to give hyperventilation. Am I right, madam? Correct. So she has endorsed what I am saying.
Uh, there was a lot of heated discussion in the morning of how much lasing of the mucosa is too much, either in the ureter or in the pelvis of the kidney. What is your take on this? How much injury can a simple blanching of the mucosa be injurious in terms of long-term stricture formation and things like that?
Okay. So for the, you should try to avoid causing injury to the mucosa. That is point number one. Secondly, with the thulium fiber laser, the depth of penetration is 0.4 mm. So which is quite less. So even if you by mistake touch the mucosa, the damage is going to be very less, especially when there is a large space like a pelvis or calyceal system. In the ureter, I at this moment preferentially I used only holmium laser, and especially in an impacted ureter where the stone is very much impacted, so that I don't want to, because there are possibility of production of the spark, heat generation, and so that is the reason I use a holmium laser in the ureter. I will not like to cause any kind of a damage to the mucosa if possible. But the depth of penetration is very less. So I don't think, now you can see that as we go into the center, the stone is becoming hard. And you can see the carbonization and
Yes.
even the sparks also.
Yes.
Even if I'm keeping the same distance of the laser fiber, I'm not even trying to dip my, if I dip it like this, supposing, then it will produce a lot of sparks like this. You can see that?
Yes.
Sparks. So I'm not
Yes.
doing that. I'm just keeping slight away. It may take little longer time than when you are in a constant touch with the stone, but that's okay for me.
So are those sparks injurious or are they okay?
Uh, they are injurious when the sparks are very close to the mucosa. Right now, here it is not going to be caused problem. But when you are very close to the stone, also sometimes the stone fragments, and I try to avoid fragmenting the stone. I would like to spend 10 minutes more in the operation theater than uh, producing multiple fragments. Then, because once you produce the fragments, you have to retrieve the fragments. So as far as possible, I would like to produce dust which are the kind of dust I am producing, so that I am not spending my time to retrieve those stone fragments, and the stone can get cleared on its own. As you go into the center, probably it will be difficult to produce kind of a job I'm doing at this moment. Okay.
Actually, one of the reasons for a very clear vision is the unsung hero behind you, who
Of
is
course.
giving us a very good irrigation.
Of course.
Would you like to describe his technique as to what you have asked him to do while you're doing this? How much irrigation he should do? How hard he should press?
He should not press it at all. Actually, you don't need a um, assistant like Khali or Arnold Schwarzenegger. You don't have to have a very soft person like Rahul to assist you, who will not push the fluid very hard, and he will be pushing a fluid very gently, sufficient enough to give me a good vision. But sometimes, if you push more fluid, sometimes you get slightly better vision than this, but you don't need it. So your vision should be good enough to give a mm, good surgical outcome, rather than producing raising the intra pressure and producing lot of post-operative problems. So Rahul is doing fantastic job, and he's using a. Can you, if you can show the cameraman, please?
Yes, please show us the secret of Rahul.
Is gently pushing the fluid. If I'm not getting a good vision, is slightly pushed like what Dr. Nanjappa today morning demonstrated. Otherwise, you don't need a very fluid to be pushed with a lot of pressure, and that's the reason I use even a 20 ml syringe, Because with the 50 ml syringe, when you want to push the fluid, you need to apply more pressure. I am sure that you agree with that observation, that with the 20 ml syringe, you pushing the fluid is become very, very easy and gentle.
Center of the stone, what is your laser? Same or
No, the laser setting remains at this moment the same. I am not changing at all. It is the same setting which I have been using. I am again going from the periphery to the center in order to reduce the stone to the smaller size. And I'm sure that this stone will take about total 30 minutes of time. This is what I believe, and which is, I think, sufficient, been good enough time for patient to spend for RIRS. And he will be home in next day.
So would you compulsorily put in a DJ stent?
Depend on the size of the stone, but when I'm doing in a workshop, yes, I will 100% put a stent.
How is it in your private practice?
In supposing if it's a very small stone up to 1 to 1.5 centimeters, sometimes you have produced excellent dust. In that case, probably I may not put even a stent. I just put a ureteric catheter and see.
So even if you have used a sheath, a flexor sheath,
Yeah.
still you would avoid putting in a DJ.
Yes. So for when you put a ureteral access sheath, it is recommended that you put a double J stent because sometimes it can produce a edema. But if you have finished the procedure in about 20 minutes time, I don't think it will matter but if you are staying a longer time in the ureter, or if the ureter was too tight, I think probably it will be a good idea to put a double J stent.
Yes, I agree. Do you do RIRS without a flexible sheath?
Yes. Sometimes because the ureter is not that great, and if the stone is very small, sometimes I backload the scope over the guide wire and finish the procedure without ureteral access sheath. But frankly speaking, I'm a big lover of using a ureteral access sheath, especially when now smaller caliber ureteral access sheath are possible to use, and you can use even a digital scope with a smaller caliber ureteral access sheath. So my personal preference, yes, I am a big lover of using a ureteral access sheath, but some people say that it's not necessary. And now I just wanted to, when we are discussing about the ureteral access sheath, I just wanted to tell you one thing, that Dr. Oliver Trexler's one paper which is very much in discussion. Wherever you go, no conference is complete without showing the picture of the ureteric injury followed by ureteral access sheath. I would like to tell you 2-3 things. That in that paper,
See, just before you go to that answer,
uh,
see now the fiber is getting burned and it's coming close to the scope. So how near is really close?
okay, so generally, if you remember, now here you cannot see the fiber, now blue cladding, okay?
Yes.
So now it is said that if you see the blue cladding, the fiber is at least 3 millimeter out of your scope.
Yes.
So it is more out than what is seen. Supposing if I do like ECRI's case, you will see next time when Dr. Aditya and Chandra Mohan are doing. If you visualize this same fiber with the PCNL scope, probably you'll feel that this fiber is more out than what it appears with the flexible uteroscope.
Correct.
Right? So if you see this much of, normally it should occupy one-fourth of this screen. If it is too much outside, it will hamper my movement. That is the reason I'm keeping this much out.
Yes.
Okay, so general recommendation is 1/4 of the screen should be occupied, but sometimes practically it is not possible.
And maybe we should also keep an eye on the aiming beam, because sometimes only the sheath of the fiber remains there and the actual glass fiber is much inside as it burns.
Okay, so for that aiming beam, you must have seen that my pilot light is almost zero.
That was my next question.
Yeah, so it is 0 or 1. It is 1. I keep 1. I do not want to, because the stone is yellow and the light emitted is green. So if I keep it too much outside, it distracts my vision. And that is the reason I don't keep it too much outside. Sorry, I don't keep that much of light. I don't need it. But because I can visually see it, what I'm doing it. And there you can see a very limited glow, green color glow over the stone.
But maybe a newcomer should make it a point to have a visible aiming beam.
Yeah, he can do that. Only thing is that it should not distract his vision. The point is that in the order to see the good light, it should not distract the good. Now anesthesiology is made up. Probably you need to give a little bit of uh, hypoventilation, decrease the tidal volume, because the stone is becoming smaller and smaller now, and then it may cause some problem.
When is the time to change the sheets?
When is the
Time
time?
to change the laser fiber.
Laser fiber.
Means you want to cut it.
No,
Jacket.
yes, okay. So Dr. Texture suggested that for, when you are using a holmium fiber, and which I am doing in my practice also, I cut the laser fiber every 15-20 minutes. Because the holmium fiber, the fiber burnout is much more than the thulium fiber. So for the thulium fiber, I think I don't need to do that. I make if once I start feeling that the laser fiber is not emitting desired energy, in that case only I cut the laser fiber about 1 centimeter.
So do you cut it or do you peel it?
I cut it straight away.
You don't
straight away.
strip it.
I don't want to see that glass fiber, because again glass fiber is very transparent. So sometimes I get misguided. There was a study which was performed by Dr. Texture again, that even if you have a laser fiber which is stripped off or cut flush, the amount of laser energy emitted remains the same. So I don't, you must have noticed that there is no glass tip projecting beyond this blue thing. So you can see that the now stone is reduced significantly. I can push this stone into the one of the calyx and do popcorning also, in case if I want to speed up the procedure, or I can gradually do the way I'm doing it. But I'm sure that by the end, while we'll finish, I would not have taken more than 30 minutes to finish the procedure. So right now it is 13 minutes and 39 seconds is my lasing time.
If you go for popcorning, what will the setting that you will choose?
Okay, so for the holmium, and if you are using a low power laser, I think popcorning will not be that effective as compared to the high power laser. Okay, because with the popcorning, it is said that you have to have a frequency at least somewhere between 30 to 40. That will be the frequency, and you have to use a long pulse, and the energy should be 1. So high energy, high pulse is recommended for the popcorning. For the thulium fiber, I think I am not using a popcorning technique. I'm using this technique, what I'm demonstrating to you. And if I want to do that, I think I will have 1 joule and 20 frequency. You have to
Sometimes the stone particles retropulse in the scope.
Sorry.
What trick you apply for that?
Sorry?
Sometimes the stone particle retropulse into the scope and the vision get blurred.
Uh, if you are, did you notice that in this case? Usually it is again recommended that if you keep your laser fiber at least.
No, no. What he wants to ask Dr. Kandarp is if there is some mucosa or some stone fragment that comes and sticks right in front of the scope,
Okay.
and your
Okay.
vision gets
Got it.
obstructed.
Got it.
somehow.
Like I think you must have noticed that it happened once here in this case also. Then you withdraw the laser fiber, just slightly withdraw the scope, tell your assistant to flush, and again here. Or you can touch the mucosa like this, and then it will be gone. The vision will be clear. And if even if it doesn't happen, then you have to take out the entire endoscope and then do probably clean the tip and then again go in. But I think it is hardly necessary, which is very rare. Now you can see that I'm very close to this mucosa is here. There is a stone is. So I have to be careful here because if I produce sparks here, it might damage this mucosa. Okay. So I have to have very good laser control. It is said that you should be able to write your name on the stone with the laser fiber. That should be your laser control.
The patient's name.
Patient's name. Okay. Patient's name. Most of the people love their name, and so they are very careful about their name. That is the reason I said your name, you know. So,
Hello.
Is the
Kandar, this is Prashant here.
yes, dear.
Yeah, there are few greenish blue like thread like structures which are coming out of the
Laser fiber,
yeah,
laser fiber,
laser fiber. So how do you deal with that? Do you just leave it and it gets
No.
out of the system?
Yeah,
or-
it gets out of the system. These are very tiny thing, you know.
Oh, yeah.
Supposing if you
Yeah.
these are all magnified stuff. This thing you
Yeah.
are talking about.
Yes, yes.
That is, I mean, you can if you have a basket, you can take it out if you want. But I think probably you will not be able to grip it with the basket also. So probably it stays inside and it will come out with the stone dust.
These are thin polyamide fibers, which makes the sheath of the fiber.
No, no, I got it, but
So
then
we
does it
leave
get retained?
No, even small broken pieces of laser fiber also, it can
मैडम
be left as it
पेशेंट
is.
थोड़ा आपको
They
रेस्पिरेशन
pass
देना
it
है
out.
तो दे दीजिए, मैं वेट करता हूँ 1 मिनट के लिए.
Like stone
बराबर है ना
fragments
पेशेंट
pass out,
आपका?
that this thing also passes out.
हाँ. So many times, you know what happens? You can see this blood clot. Now this blood clot sits on the stone like this, supposing, and then vision is hampered. Then you can start doing lysing the. You can lyse the uh, clot like this. Then it will open up the stone. Okay. So sometimes it happens that your stone is covered with the blood. What will you do? In that case, you can lyse the clot, and then the stone, the clot will disappear.
Sometimes the clot actually helps to keep the stone bound to the pelvis or the mucosa, so it doesn't wobble too much.
I have found clots helpful in case of retrieving the stone fragments, small stones, like people used to use autologous blood. They inject the autologous blood in the lower calaceal stone especially, and then fragment the stone into multiple pieces, and then it will help you to grip the stone along with the clot. So I have not tried that. I wish to try it sometime.
It's like coagulum pyelolithotomy.
Yes, coagulum pyelolithotomy, correct.
That happens in theory, but not in theory. It happens. It works in theory, not in actual.
I have no idea. I have not used it. So, but I think there was a paper on it, and they have found it little helpful. But I have never tried it. And some of the paper,
Submiss.
yes. I was
We
talking
have done
about.
it 3-4 times, but you have to put the blood and you have to wait for 5-7 minutes. Then only it will come out. These were the small tips and tricks, maybe in the non-flexible open case days.
Now this stone is going towards the upper calyx, right? So what I can do is the upper calyx. With the laser fiber, I can bring the stone somewhere.
It into
Again,
the
either
calyx and
either put it into the calyx or take it out and put it into the same position where it was.
push it
So
into
let
the
me go
calyx.
there, and then with
and
the help of
popcorn.
my, you can see I'm changing the direction. So I have brought it out. Did you see that?
Yeah.
I can do, and this has flipped the stone also. So again, this is when you flip. Don't push the fluid, please. This moment. Then dusting again becomes very easy because again you are at the periphery. So dusting is much quicker. So it will be easy to reduce the size of the stone. This I did it only with my hand movement as well as with the laser fiber movement.
And there we give it a name in the morning, ACDC.
What is that ACDC? Again, अच्छा आगे से
I'll tell you later.
ओके
The video cam is on, so
ओके So Jackie, but now you are happy, yeah? At this moment, we didn't have a surprise for this case.
happy for you.
Happy for me.
You are working at your pace comfortably. Everybody is relaxed. There's no stress. I wish all RIRS were like this. Fortunately, surprisingly, today, all the RIRS, the stones are sitting in the pelvis nicely, pre-stented. Really, really, reaching the stone takes 10 seconds. Sometimes you'll end up in a situation where the stone is lying in some corner calyx and you're struggling to even see the stone. We have not, in the last few cases, we have seen not a single one in the inferior calyx. I don't know, there's some jadoo of Bilaspur
You want me to
urology.
you want me to put this stone in the lower calyx
And then
see?
restart all over again.
Sure.
Very good. This question should go to Prashant Bhagwat. I'm asking Prashant and Kamlesh only.
Uh,
कि यार यहाँ का स्टोन अलग ही लगता है.
Happen to
What to ask?
what?
I think they
Yes.
washed out already, What's
we
what,
saw him washing out. It's a case.
what is the status of Dr. Shabir's case? Can we know in the hall?
Yeah,
You,
let's
you,
go
you,
back.
you please go to Shabir, then I'll come back to you.
Yeah,
No problem.
Skip to the other theater. Is it on or was there?
It's on. This is what I am told.
Dr. Kamlesh, can we shift the theater?
प्रेस करो 1 मिनट आ रहा है बस अब पीछे लीजिए
Yeah,
आप
Dr.
अपने एक
Shabir.
सेकंड तक
Shabir
पीछे
ji.
लीजिए।
We are back with you.
एक सेकंड बस ओके ठीक है ये इमेजिंग ऐसे रखना तो है भी जब टू टेक अ पंक्चर नहीं होगा इस
Dr. Shabir, good evening.
नहीं पकड़ो
Dr.
नीडल
Shabir,
देना नीडल अभी नीडल दो
Dr.
यान दे दो
Shabir,
राइट दे दो यान दे दो मेरे पैडल दे दो यार मेरे को कहाँ पर है दे दो ना
Dr. Shabir.
सर
Yeah, hi. Good evening. We are back with you.
सर
It's a long case for you. We know we started with a good afternoon, but it's good evening.
yeah sir
And-
what we have done first with the puncture only we could we have emptied you can compare just show this image
The
the
Siam
current
image.
image sir, this stone is also very sticky
Okay.
so we are doing with the shock pulse is not working as efficiently as I was expecting.
Okay.
So it took a long time, and then we are removing with the force bit by bit at times. And then we have emptied, and we took one more puncture, but that puncture from inferior calyx is not giving a good access. So I plan to take one more puncture for the residual stone, which we are seeing in the middle part.
Okay.
Otherwise, rest of the part we are seeing, we can show this the betadine coming from the below, the pelvis part and the UPG area is clear.
So this is the middle calyceal component that remains.
That remains, that will require a puncture because now it is.
Are you planning it today or at a second stage?
I'll just see, take a try once, and if I succeed, then I'll do it. Give me Siam, please. Siam, please.
Sorry? About a second stage? No.
I think if anesthesia people say, then if it's a prolonged anesthesia, can go for a second stage and we can put even DJ stent at this time because we are having an access.
Depends on the patient's condition
Yeah.
and yes.
Doctor, can we trial for a puncture or should we staged it? Can try, okay. He's not allowing me to go, sir.
You carry on.
Yes. So show me the CM. Okay. I
You are
think the
not getting the
contrast will
patient
not
image.
work. CM, please.
Give us the surface view.
What is
Yeah.
here?
I'm just trying to hit the stone and the guide wire. What happens? Give me please the CM. Okay.
Can we have the IRTV view?
Give us one view of the surface and one view of the C-arm. So now you are maybe triangulating and trying to hit the stone directly.
Yes, sir. I'm trying to hit the stone directly, and I have hit the stone because I can feel the stone here. Feel the stone. While moving with my needle. Give me a little bit contrast.
But do you think there is a more peripheral stone there, two in number?
Yeah, sir, but even those peripheral stone we have seen in the city, they can be secluded. So even I want to remove that large burden rather than targeting the small stone, which may not give me the access for the large burden. There is the IVP film also, but there is non-excluding contrast from here. Contrast from here. Let us see. Here I am. See, sir.
So it looks like one of the calyces.
One of the calyx with a large burden, and the peripheral stones have got a very narrow connection. When I put, I may not able to reach the large burden from there, so I'll dilate this area only. And from that, if possible, we'll go the smaller side nephroscope and try to laser out those stones. Give me 12 French. Laser here probably. I may not dilate that much. Do you have a size probe? लगाओ उसमें। मेरे को मत दो यार। 12 दो। M+ नहीं, तो इसी के ऊपर मिनी रखा है क्या? मिनी पार्क में मिनी पार्क विद लेजर। Give me mini park. Keep laser ready. Pulmium is ready or? टॉस दे दीजिए, दे दीजिए। चलिए ये दो दो। पानी डालते जाइए नीचे से। Let us see. रेडी करिए। No, no. Water, please. ये पानी ऑन कर संभाल। है क्या हमको थोड़ा लीजिए।
Hello.
Yes. Hello.
Yes. So, are you with me or you are with?
Yes, we are with you, and we can't see any stone
Yeah,
as of
there is a
now.
one stone now. This large stone is reduced into this stone now. So here I've got two options. I can still further go on, or I can fragment into 2-3 pieces, and then I can take it for the analysis. So this is how you can, if you are, I think, slightly patient, in that case, your patients pay for it, and then you can produce a very nice dusting. And
We
you
are
can,
patient, but not as patient as you.
and you can see the kind of a dust we have produced. You can see entire urate will be collected.
Yes, very
And there
nice.
is a lot of dust. And so you can see all the dust. And so now I will still try to produce a little more dusting here, and then take out the last piece as for the analysis. So राहुल, आपने बास्केट अगर है तो आप मेरे को take it out. So we'll take out one piece for the analysis, which I normally do. So this is how I think if RIRS is performed, in that case it can produce excellent result as good as PCNL, and patient will be, and this whatever you are seeing is a magnified view. You have to understand that you can compare it to the laser fiber. So the kind of a dust we are, like some fragments, some small chips you are seeing, they are even less than 1 mm. So it will clear on its own. Most of the times it clears during the surgery only. If you keep your scope like this, I'm just withdrawing it, you can see that lot of dust coming out.
Yes. Actually, what we
Funny
have
one.
started doing is we collect this duct at the flexor sheath outer end. So that outer end is a small concavity where some dust will get accumulated, and
Sure.
we can send the same for analysis.
I'm sure you are an innovator. I'm
Unless
sure.
unless we are looking for a specific area in the stone.
All this dust. I think when Rahul is ready, I think I'll grab the fragment out for the analysis. So, and here, like some people may like to produce a little bit of popcorning kind of a thing for this residual thing, but then I will not be able to retrieve this fragment. This is a very small fragment. So I will like to, I would like to actually take out the fragment for the analysis, which I normally do. So we'll do that. The one fragment I am leaving behind, rest of the things are gone.
So what size stent would you prefer to close the case?
I'm putting a 624 in this patient because patient is not very tall. So, and I don't want large amount of the stent to be in the bladder. I'll be putting a 624. Male patients in my practice, I use 624. Still, stents are pain. The only pain this patient will appreciate is a pain related to stent. And I think, Ashish, you must find out some way. You are an innovator. You have to find out some way how we can reduce stent-related pain. We are giving all kind of sort of medications, alpha blockers and mirabegron and flavospas and whatnot. In my practice, we are not giving one more thing. We are not giving painkillers, okay, postoperatively. We are simply giving paracetamol to the patient.
So,
Postoperative means when the patient goes home. Okay, when the patient is in the hospital, sometimes they get Dynapar or something for day one because the catheter, urethral catheter is also in, and it might produce some kind of a and catheter.
for the stent dysuria, actually we bumped into this molecule which is usually used, which is alprazolam.
Prazolam.
If you give a very low dose of alprazolam, we have found that even in resistant stent dysuria cases, they are very happy. I have not dug out the literature, but if someone has an experience, may definitely share. This is
Okay.
what you have started doing
Okay, so
recently.
the basket is in. Rahul will open the basket. You please open. In one hand, you have to push the fluid. Okay. So he grab the stone, please.
0.25.
So he is grabbing the stone.
In the
पानी
night.
डालते रहना. पानी डालता है ना कोई? Oh fuck. चल गया.
So,
Oh,
Kandak,
yes, yes.
in stent dysuria, what are the symptoms you consider very difficult? Is it the voiding symptoms or what exactly symptoms?
No. Patient usually have when they void, they have lot of pain. And,
Where,
you know,
where in the bladder or in the kidney?
in the kidney because of the
Acha.
reflux.
Okay.
That is a big problem. पानी डालना.
Okay. So, if I give you a type of stents which I have designed, would you give me the feedback?
Of course, why not? Everybody will give you feedback. Ask
Okay, okay. Thank you.
the पानी डालते रहना. We are taking out this fragment for the analysis. The fragment is out. Now exactly my lasing time. Can you show the screen, please? The lasing time is 24 minutes and 30. Can you please show the here? So such a large size stone, medium size hardness, the lasing time is not more. So in all, usually this kind of a stone takes about 40 minutes to 45 minutes to finish the procedure. So it appears very big, because you are producing a dust. So sometimes it becomes boring so that the procedure appears to be very, very long. Kam dikhana, please.
So the lasing time would be time the laser was on,
The
and
laser
that would
was-
actually differ from the time the procedure went on for.
Of course, because the lasing time when I started lasing and now I finished the lasing, so it is 24 minutes and 37 seconds.
It's like the
If-
fluoroscopy time.
Kind of a fluoroscopy time. Now, we have up till now, so far, we have not even used the fluoroscopy in this patient for my procedure. Right now, what I will do is that I will inspect the entire pelvic LSS system because I think probably might have to go to the another OR in case if they are busy. So what we'll do is that we'll do a dye study, and if you are free, I can show you that dye study also, just to see that whether we have caused intravasation or extravasation. Then we'll give all credits to Rahul, not to me. In that
Do you routinely do a contrast study? End of an RIRS?
Every single patient we do a contrast study. That is the only time usually when we do a dye study and only one shot. So my total CM time is approximately about 6 seconds. 6 seconds. So sometimes you need to give 2-3 shots. So one shot is about 1 second. So sometimes you give for 6 seconds in the entire procedure, or maybe it about 2 or 3 seconds.
Extravasation at the end of the procedure. Might see extravasation.
Okay. Okay,
Then
let's check in
what-
this patient. Yeah, first of
What
all,
special
dye de dena.
instructions
Contrast.
or precautions after that?
Pani dalna. Nothing, but we will then certainly go for a digestant. That is first thing. In case if there is a, sometimes I prefer not to put a digestant, thinking that I produce a good dusting. Why should I go for a Just end. You can see this ureter now entering into. There is no bleeding. Now I'll make evaluation of the pelvic area. Manida, the upper calyx. From where we grab the stone.
Yeah. You also see some plaques there.
Yeah, that clot was there for a very long time. You know. Tiny. The dye, please. Let us see whether Rahul is Khali or
Very gentle. He has helped you for 1.5 hours very efficiently.
Of course, he has helped.
Oh,
Really
in
thankful.
in a lighter vein.
All of you also. Long day. Have she? Now you can see the C arm now. Can show the C arm,
We
please.
don't have the.
Please, please. Just show you. ये जो C arm.
So will you put contrast under pressure or just push it through the open end with the flexor sheet?
No, I already pushed the contrast now. You can see that I've pushed it through the scope only. Can you see that?
Yes.
The right one.
Yeah.
The scope is in position. There is no extravasation or intravasation. Can you see it very clearly?
Yes.
Okay, fine. So now we'll put a stent and call it a day. So if you have any question, please feel free to ask me. Otherwise,
Yes, we have a question here. The question is from Dr. Jackie. What is intravasation?
need to.
Serious, my friend.
The intravasation, what I mean to say is that whenever there is a contrast, I cause some kind of a damage to the pelvic alyssal system, you can see a contrast going into the cortex. You think it is very, very easily visualized. Never seen?
Basically, you want to see extravasation. You want to see if we have missed some filling.
Filling defects where? If there is stone, but I do the systemic pelvic examine, pelvic alyssal system. That's the best way to do it.
That is true, but see, there are some very difficult.
हाँ, that is fine ना. वो तो मैंने बोला ना कि भाई अगर आपको if you are having any kind of suspicion, then that time you do a contrast study. Perfectly all right. Or if you are missing any stone, which is there on the scan or
Hello?
yes.
Yeah, please.
I think the Shabir wants to.
Dr. Chandramohan is he here? He used to put very small size digestant after the procedure and maybe 4 French every time. So his observation is that when you put a very small size stent, the stent related symptoms are negligible.
I think the stent dysuria or the stent related symptoms should be related to the length of the stent rather than the thickness of. So if you
Yeah,
have a
that
very
is
long,
what we think, that the
if you
length
have
in
a-
the bladder should be minimum.
yes, if you have a long dangling over the trigone, definitely it is going to be painful.
That is the precise reason
But
I
what
say
about the diameter? I mean,
The diameter, it may not be of much significance as long as the DG is not rubbing against the trigone, which is the pain sensitive of the
बताओ,
bladder. Yes.
नीचे बताओ,
Hello,
नीचे बताओ.
that's exactly, sir, what do exactly here? Eric that when he is voiding, there is a lot of loin pain. And the reflux
निकाल
depends on the size of the diameter.
Dysuria has to be voiding pain and not loin pain.
Because see why the patient develops a loin pain Because
Because
when
of
he's
reflux.
voiding, the urine flows through the urethra and
Reflux.
through the stent reflux. Uh, the size of the diameter, size of the stent, or the internal lumen of the stent make a big difference. That's the so his pain starts when he starts voiding, ends up 1 or 2 minutes after he has completed the voiding, because the intrarenal pressure decreases 1 or 2 minutes after, because whatever the fluid that has gone into the pitch comes back. So if that is a pain, that what he's telling, then the size of the stent or the diameter of the stent does matter.
My understanding was that when you put a stent, there is the drainage happens two ways. One through the stent and by the side of the
Correct.
stent. Right?
Absolutely.
So the size will not make a difference in the
So
reflux.
size should not make much difference because as such some amount of the fluid is going to go by the side of the stent because
Correct.
stent dilates the ureter and there is a space between this. So I thought that when I have no sufficient data to prove my thing, but I think this is what
Yes.
we have been taught.
Yes.
I
One
think
last
this
question.
this is
That
very
is,
thing is there. Dictionary meaning of dysuria is very clear. Painful
Yes.
or difficult micturition.
correct.
Yes,
Now,
yes.
whatever you can have urethral pain, loin pain, that is a different thing. But dictionary meaning is very clear. Painful or difficult micturition.
Correct. That
Thank you.
holds true everywhere, including the
But the
loin
moment
pain-
it is stent dysuria, it may mean something different also.
I
this
think
loin pain-
Thank you, Dr. Kandar. That was an excellent demonstration. We have to wrap up because the inaugural
yeah,
time
yes,
is
yes.
already up.
Thank you so
thanks,
much.
Kandar.
Thank you so much.
I would
Thank
ask
you, everybody.
I would ask the opinion of the house regarding the stent related issues in triple J stents rather than double J stent.
Triple J stents.
Yeah, there are some something like a Dalila stent. Yeah. So any experience
No, I
regarding
do
that?
not have any experience about the Dalila
Anybody
stent.
anybody in the house?
Actually,
Stent, we
Dalera
have
stent
used.
conceptually is very good, but I fail to understand that what makes it to stay just at the vascular junction and then immediately loops up. Stent can come down, and that whatever the stent part has come down on the trigone is going to stay there.
But
There is
Dalila
no
stent-
mechanism for that to stay exactly where it is bending to stay there.
If you remember, one patent has been accepted of mine. Call it the happy stent. In the DJ actually doesn't form a coil, but it goes back over the bladder itself. The problem is technically we are still not able to manufacture it.
So Dalila stent, we have also many cases. But beneficial us of mixture.
Yes.
So the of mixture stent because of the abscess.
Yeah.
That's a very valid point.
Yeah.
Hey.
Prashant Mulaukar, back to you.
Yep.
A break
So
for
there is
5
an
minutes.
announcement. Yeah, let me
Prashant?
invite Dr. Prashant Mulaukar and Dr. Jaiki to give no, not for this, to give the mementos to the chairperson.
There 5 minutes break.
And then there will be a 5 minutes break. We'll have a cup of tea on the first floor, and then we'll reassemble again for the inauguration session.